Okay, hello everyone, and welcome back to another VMR. Today I have the great honor to discuss a case with the one and only Jack. And before we start, I would also ask a question into the audience. Is there someone participating for the first or second time? If yes, please raise your hand. And we would also appreciate it if there's someone who would like to present a case to us. So if you have one, please write on the chat or raise your hand. I would be very honored to discuss it.
Yes, it is a very, very special day. Shema, the honor is all mine because I get to discuss a case alongside you. We're going to have a great time today going through a speed round of our usual 30-minute VMR. So yes, if it's your first or second time here, as Shema said, please let us know. And if you have a case, please also let us know because we are on the hunt for one. We'll practice holding the silence for a couple more seconds. I see some names on here of individuals who have a high pretest probability of having a case. I won't call anyone out, but we'll see where things go. Sometimes we have a backup, but I'm worried that today will be a backup free case, in which case we'll be relying on you all. All right, well, I will turn over to see if Yasmin potentially has one. I see a head nod.
I got one, like small, sweet, short. Like I think this will be easy.
Oh, don't set us up for that, Yasmin. It'll be challenging and difficult for us to solve, and it will be amazing when we do so. That sounds great. Thank you for bailing us out, Yasmin. All right. And Vali, are you good to scribe? Awesome. Let me make you co-host. Okay, I think you're set up there. All right.
So for today's case, a 61-year-old male presents to the ER with syncope. Do you want the characteristics of it?
I
think let's just stop there for Shema. Okay. Shema, take it away.
Okay, when I think of syncope, we always go through our 6S schema. So for transient loss of consciousness, next to syncope, you can think of sugar, like hypoglycemia is one of the most important causes that you can treat. Then you also think of a stroke or a TIA, then substance abuse, and then also of sleepiness disorders like narcolepsy and stroke, seizure, sugar. I think I have it all. Yeah, that's one thing that I think of syncope. And before going more also into detail, I would also ask, like, especially what's the past medical history? Is this person taking any medications? Like an older person, I always look into things like, is he taking benzos that could predispose him for altered mental status or any opioids? And then when I think of sugar, like you have to know, is he able to eat well? And also for stroke, is he having any cardiovascular risk factors, especially in an older male? We can expect that. And yeah, I would now give it to Jack.
No, Shema, I think that is absolutely brilliant. And I just want to elevate the reasoning decision that you just made, which is to adjust the chief concern from what it's labeled as to what the broadening the possible clinical syndrome that we're dealing with, because somebody is coming in being labeled as having a syncopal episode, but all we can really glean from that is that they indeed had a transient loss of consciousness, one cause of which is syncope, but there's many other causes, as you alluded to, and exactly as you said: seizure, syncope, stroke, hypoglycemia, and substances being the 5 S's. So I think that's a phenomenal reasoning point for everyone to take home, is like, if it's called syncope, we might want to temper that and translate it to transient loss of consciousness, of which there are many causes, of which syncope falls underneath it. And deciding between these different causes of transient loss of consciousness can be really difficult to tease out, because the event itself, especially if we haven't seen it, will usually be reported in the same way, right? We'll be told that somebody had a loss of consciousness. And so for us to tease out whether or not we're dealing indeed with syncope or one of the other 4 S's that remain requires us to not only understand the event itself, the loss of consciousness episode, but also whether there were any signs that it was coming and whether it has left any trace behind, right? So there's really 3 things that we can use to delineate through these symptoms, right? Or through these 5 S's. We can use the coming, the event, and any trace that it left, right? The event itself can be quite enlightening if somebody witnessed it and noticed things like head turning to one side and rhythmic jerking movement, in which case we would upgrade from syncope to seizure. But more often than not, we don't necessarily have a witness. And so understanding from the patient or any bystanders what signs there were that it was coming. If somebody had palpitations preceding it, shortness of breath or chest pain beforehand, right, we might move towards the syncope side of things. If somebody felt like the curtains were coming down and they had just stood up before they lost consciousness, that might also favor syncope. If there's a predominance of autonomic symptoms, for example, sweating and feeling shakiness and jittery, right, we might actually move from syncope to hypoglycemia. And so I think getting a better characterization of what signs were coming, and then also understanding what might remain now, right? If somebody continues to be altered after their transient loss of consciousness, the probability of a post-ictal state or a substance starts to go up as well. And so I think that is sort of, I'm right there with you, Shema, in terms of thinking about, yes, this may end up being syncope, but let's verify with the history and the other trace that this loss of consciousness episode may have left before we for sure deploy our syncope schema. All right, Yasmin, take us away. Give us some more.
Of course. So this patient with syncope also referred that he collapsed. When he arrived to the ER, he was initially diaphoretic with dizziness and non-specific chest pressure after suddenly standing. Do you want the medical history and medication?
Sure, yeah. Why don't you take us through the background medical history and meds, but we can pause before the physical exam.
So for his past medical history, he has poorly controlled hypertension. He's a multi-antihypertensive that recently started, and he also refers a similar episode playing tennis 1 month ago. His medications are metoprolol, lisinopril, amlodipine, and atorvastatin.
All right. Well, so I will say it seems like there's sort of really two things that are really coming into the center of gravity here. One is that the patient was able to tell us that he indeed was the one who collapsed. And so I think given the fact that we have what seems to be alertness, right, and the absence of a post-ictal state, we can take 1 or 2 of those 5 S's, or potentially 2, off of the DDX, right? Individuals who have a seizure are oftentimes post-ictal afterwards, and so they may not be able to say what or tell us exactly what happened. And then also most substances that cause losses of consciousness tend to leave a trace of encephalopathy afterwards, if we think about things that are sedatives, for example. And so indeed, I think the picture is moving more and more towards syncope for those reasons, as well as the fact of what's in that southwest corner of the list here, right? We see a predominant cardiac history. And when somebody has underlying cardiac disease and they have an episode of syncope and collapse, right? Or I should say an episode of loss of consciousness, right? There's the possibility that their cardiovascular disease is on the hook here. So I think more and more what this background information helps us do is start to actually move more towards the syncope, the likelihood of this being a true syncopal episode, the causes of, or the potential causes of which I will turn it over to Shema to take us through.
So amazing discussion. What I would add, so we see he has poorly controlled hypertension. What I think of, especially when we think of a stroke, like he could be at any risk for intracranial hemorrhage. And also seeing that this episode happened while playing tennis. And I remember, if you like playing tennis, you have to lift up your arm, and there are several structures that can be compressed if you think of something like thoracic outlet syndrome. Like I know the structures that can be compressed. It could be the subclavian vein, it could be the plexus, and it could be also the subclavian artery. And it's, I think, if it's isolated only the subclavian vein, um, and that's especially if you lift up your arm. There's also some test that is called, I don't know if you ever heard of the Edson test. It's like basically if you turn the head to one side and if you want to palpate the pulse, and if you don't feel the pulse anymore, this could be an unspecific sign for something like thoracic outlet syndrome. So especially people that are playing disc golf or anything with tennis could be maybe at any risk for that. And also seeing that he has some chest pressure. If I try to combine these two together, like I feel like this could this kind of stasis, like if you think of the vicious triad, like stasis, hypercoagulability, or endothelial lesion, something like this could predispose him for a clot forming. And this could also lead to something like a pulmonary embolism, which could cause something like chest pressure. But yeah, that's my initial thought on that.
Shima, I think that analysis is brilliant, and I appreciate so much how you're pulling in to say, okay, if we have what we think is a syncopal episode, there's three primary buckets that we can have, right? We can have vasovagal syncope, we can have orthostatic syncope, and we can have cardiogenic syncope. And the cardiogenic syncope bucket can include both problems with the heart, but also the vessels that lead into and out of the heart. And I think it's a brilliant call that the presence of chest pressure alongside the what seems to be, again, a syncopal episode, right, brings the thoracic cavity in there. And there's a whole host of things that could be thoracic causes of syncope or loss of consciousness, and thinking about those ones that you mentioned, whether it's a potential thrombotic episode, or if we think about other potential obstructive problems within the heart, for example, aortic stenosis that could lead someone to have exertional syncope or syncope associated with chest pressure. The one thing that I would love to get your thoughts on is like how the diaphoresis is influencing things at all. Yeah, how, like, the fact that he's diaphoretic in some way. Are you tracking that, or is it sort of falling into the background? I'm curious what you're making of that.
I have to say, when I think of diaphoresis in that kind of context, it makes me think more of something like a sympathomimetic overreaction. Like if you have hypoglycemia, you can be diaphoretic, and otherwise also something like how is it called? Withdrawal. You can be a diaphoretic, or I think like some endocrine disorders like hypothyroidism. Yeah. And also like yeah,
No, please.
People with myocardial infarction or any kind of stress reaction are usually diaphoretic.
Yeah, I think that last point is so important, right? Is that when we see syncope alongside diaphoresis, right? We mentioned at the beginning that the possibility of a hypoglycemic event comes up, but the coexisting presence of chest pressure here makes it so much more likely, as you mentioned, that the diaphoresis is actually a sympathetic response, not from an potentially metabolic problem, but potentially from whatever pathology is emerging or progressing within the thoracic cavity. And so it's interesting to see how the diaphoresis might be a red flag for one DDX, but when it comes alongside another friend, in this case, the chest pressure, it almost heightens the center of gravity on saying, okay, what's potentially happening in the chest, and how is that potentially influencing this loss of consciousness episode? All right, Yasmin.
Of course. So I really like your discussions. I think that whoever presents may feel this way whenever we're listening to your reasoning. Anyways, I won't say anything else. So for the physical exam, we have heart rate of 110, and we only have a systolic blood pressure of 190. We don't have a diastolic for some reason. The patient is mildly ill appearing, sweaty, though he's awake, alert and oriented on the three spheres. And he states, I just don't feel good. There is significant orthostasis, normal heart sounds, the lungs are clear. There are equal pulses in 4 limbs. Now, for the next part, I have the labs and an EKG. I don't know if you want me to keep going.
Yeah, why don't you go ahead just for the sake of time?
Okay, so we have white blood cells of 15 with 75% of polymorphonuclears. The rest is normal CMP, and a mildly elevated troponin of 0.2. And our EKG, we had sinus tachycardia with frequent PVCs. The paramedics present a rhythm strip with a wide complex bradycardia. And in the ED, the rhythm briefly changes to wide complex tachycardia. Then there is a predominant rhythm afterwards with a narrow complex tachycardia. So he has 3 different EKG strips that starts varying.
All right. And it sounds like those 3 are, or at least a component of it is a sinus tachycardia, a wide complex bradycardia, and a wide complex tachycardia.
Yeah.
Okay, awesome. Shema, feel free to take us through your thoughts.
So first of all, when I think of sinus tachycardia, I would usually expect that the blood pressure is actually low, like in physiologic tachycardia, but we have the combination of tachycardia together with high blood pressure makes me think more of sympathetic toxicity. Still, it could also be due to his poorly controlled hypertension. This constellation made me also think, especially with the syncope, also of a complication like PRES, this posterior reversible encephalopathy syndrome, where people with hypertension are at risk for bilateral vasogenic edema in the posterior area. And now seeing the EKG with the bradycardia and wide complex tachycardia, I have to say, when I think of tachycardia, as you say, we think of is it wide complex or narrow complex? Because when I think of something wide complex, it's usually more dangerous. So before I think of what could actually cause it, I usually treat it. So seeing that he has syncope, but also like what I always learn is like how I treat wide complex tachycardia. If he is hemodynamically unstable, has signs of syncope, we would usually shock the patient. Like we would use the cardioversion. What do we say? Cardioversion or defibrillation. And if he is like not hemodynamically unstable, we would usually use medications like amiodarone in a short infusion. So this is the basic approach that I would do here. And when I think of bradycardia and also of wide complex tachycardia, I mean, I know electrolyte imbalances could do that, like something like hyperkalemia. So I would be interested, how are the electrolytes? And also, I have to say, when I look into the medications, I don't actually see something that could predispose him. Like I know if you take too much ACE inhibitors, which could predispose you for hyperkalemia, but you're also taking metoprolol, which could cause hypokalemia. So yeah, I have to say, I'm at the moment, I need some help.
No, Shema, I think you need no help at all. I think that was an absolutely brilliant analysis. And I think, you're highlighting really what are really important tensions in terms of where we're at right now. And I think if we, how do I say this? I think a way to make progress in this case is to ask ourselves where we want the center of our thinking to go here, right? Because there's so many pieces of information that we just got, particularly with just this comp, right? Anytime the EKG strip takes up 3 lines, you're dealing with a potentially confusing heart rhythm. And so what I'm trying to do in my mind is distill this down to say, what are the sort of most morbid or the can't miss diagnoses that we could be grappling with here? And I think if we take just the findings alone of somebody who has known cardiac risk factors, chest pressure, diaphoresis, a sensation of feeling unwell with a new wide complex tachycardia, the possibility of underlying ischemic disease comes up quite high on the differential. The question then is, well, how do we also reconcile that with what happened a few months ago? And I think that there's, I would say, a few different ways for somebody to develop cardiac syncope. But I'm just going to see if I can pull up this Evernote here to walk the group through this. Give me 1 second here. Because I think asking ourselves, right, in somebody who has a known history of cardiac disease, who's having a syncopal episode, the question then becomes, well, what could potentially be driving that, or what underlying cardiac condition could be doing that? Give me 1 second. I'm not quite as dexterous as I would like to be here. All right, here we go. Pull this up. Can you all see this okay?
Yes.
Okay, and so the reason that we can sort of look here and say, gosh, could this be cardiac syncope here, is some of these different elements of the history, right? This is somebody who had an exertional syncopal episode a few weeks ago, right? We said that there's 3 primary categories of syncope: orthostatic, vasovagal, and cardiac. And the fact that this is somebody who has underlying cardiac disease and had an episode of exertional syncope and is then coming in now with an arrhythmia after the syncopal episode makes us think about the possibility of underlying cardiac syncope. And there's really 3 big buckets of causes of cardiac syncope. We can have arrhythmic disease, we can have structural heart disease, and then this entity that I refer to as cardiac plus, which means the heart's on the hook plus another organ, whether it's the heart plus the lungs with something like PE, or the heart plus the aorta with something like dissection. We have a good sense that there's a possibility of an arrhythmia here based off of this EKG strip, right? Bradyarrhythmias can certainly cause underlying cardiac syncope through things like AV block, usually the higher grade AV block, or very, very high sinus pauses. But we also aren't just dealing with bradycardia, we're dealing with wide complex tachycardia. And when we see a wide complex rhythm that's tachycardic, it is VT until proven otherwise. The causes of VT is a long, long list, but if you remember 2, I want you to remember ischemic disease and non-ischemic disease. And so the fact that we have a syndrome of somebody who's had who has known cardiac risk factors, chest pressure, a subtle troponin elevation, who's coming in now with what seems to be a wide complex rhythm, the exclusion of underlying ischemic disease, like an acute coronary event or an acute coronary syndrome, becomes the most important thing here. And then once we've excluded the possibility of an acute coronary syndrome, right, which could involve actually taking this patient directly to the cath lab to look at his coronary vessels, then we can move on to many of the other causes. One thing to think about before we potentially think about taking this gentleman to the cath lab to evaluate for an underlying ischemic event, which is going to expose him to an enormous amount potentially of anticoagulants, is asking ourselves, actually, could we be dealing with an aortic problem here? Because aortic dissection could lead to a syncopal episode, and this gentleman has very, very high blood pressure. So there may be a situation where we say, gosh, the probability of ACS seems high enough, a decision that we might make alongside the cardiologist, right? We might ask the interventional cardiologist and look to her for her expertise to say, you know, is this somebody that you would take to the cath lab now? And this patient may make a pit stop on the way there at the CT scanner to make sure that there's not a dissection happening. Although, as was mentioned in the chat, the normal pulses in both arms takes that probability down some, but we would have to ask them if it takes the probability down enough. And I think once we're able to exclude or prove the ischemic hypothesis, we can then move on to that brilliant differential that you took us through, Shema. But I think the features of syncope, chest pressure, diaphoresis, and these other background histories make me worry that we're dealing with this here. The question of the bradycardia being there, I think, is an interesting one. Certainly a sick heart can ultimately develop abnormal conduction disease, but we also have to explore the possibility of something like the AV node potentially being ischemic from a right-sided lesion. So if there's ischemia to the AV node, individuals can go in and out of heart block, and that might give us some hint that if there is a coronary vessel occlusion, it could be a right-sided lesion, but possibly as well. The other thing that would support that is the prominent orthostasis, right? When we stand up, we lose so much preload, and so that also, it sounds like this gentleman was potentially orthostatic, which may also suggest that there could be an acute hit to the right ventricle, but it ends up being conjecture without the actual images in the cath lab.
That was an amazing discussion, actually. And I have the last part another lab, but that will give you the answer as well as a CT scan. Do you want to see it?
Yes, please.
Of course. So let me share my screen. This one, I don't know if you can see it. Right, there it is. Actually, it's shown there. Should I tell you what they found? But it will give you the diagnosis.
I will say this almost every time we get a radiologic image, which is never send an internist to do a radiologist job, but we can try to think through it together. Gemma, let's just play with this. What is a big circular structure that runs down that part of the body?
Well, on that part, I was actually thinking, is there something with the celiac artery coming from the aorta, or am I seeing wrong? Oh, oh my gosh, it's the aorta. Okay, yeah, it's on the left side, yeah.
I agree with you. I am concerned that is potentially either a big aortic aneurysm or as we had mentioned, an aortic dissection there. But I would be curious to know what the formal radiology read. But I'm with you. I'm having a hard time orienting myself totally without being able to scan. But a big tube on the left side of the body in the abdomen makes me say, is there aortic pathology?
Okay, so what it reported is that on the chest CT scan, they found an incidental granulomatous disease in lungs and a benign appearing tumor of 4 centimeters in the left adrenal. That's what they found. So they also had a urinary catecholamine studies, and they found excess catecholamines.
Ooh.
So it's given us the diagnosis of a pheochromocytoma.
Wow, so we're dealing actually with a case of secondary hypertension. That's so cool. I mean, I know of when I think of pheochromocytoma, how it can manifest. It can sometimes mimic Takotsubo cardiomyopathy, but it doesn't. But it's if you have someone presenting with, like if you have someone in coronary angiography with sign of this apical ballooning, what you would see in Takotsubo, it's if you have also these high catecholamine levels. So yeah, I'm just mind blown because I didn't expect it.
Yeah, I have to say that me neither. I got this case from Human DX, so I you know how you have to keep your diagnosis in, and I was wrong. So yeah, so this patient was admitted to the ICU. There was blood pressure control and achieved with IV nitroprusside, although he had several periods of hypertension, which required fluid resuscitation. The MRI was suspicious for pheochromocytoma. A 24-hour urine was strongly positive for excess catecholamines, and there was left adrenalectomy performed 2 weeks after proper alpha and beta blockade with resolution of symptoms. So what makes me think that this patient started having issues was that the case states that he started adhering to his beta blockers, and the beta blockers may exacerbate the pheochromocytoma symptoms. So that's why he started feeling worse and worse since he actually started his medications. And I think that I also found is that it's very rare to find syncope in a patient with pheochromocytoma, and there are like many counted cases of this being one of the main presentations.
Wow, I am beaming from ear to ear over here, because I think one of the best spaces to find ourselves in, which is one that I find myself in frequently on VMR, is a space of feeling completely humbled and floored. And I think what that oftentimes suggests is that there's an immense amount to be learned from a case like this. And I am reveling in that feeling right now, after just taking everyone through the possibility of, oh, this seems like it could be acute coronary syndrome. We end up going into a totally different direction. So thank you all for bearing with me as I took us down that a bit of a detour road. And Shema, I just want to say thank you so much for discussing this case. You know, you were on the scent of sympathetic surge from the very get-go, which is absolutely brilliant reasoning here to sort of recognize that disease signature up front.
Thank you so much, Jack, that I could discuss with you. It's so much fun. And also thank you, Yasmin, for this amazing case. Really, I learned a lot. And also to the amazing crowd on the chat, and also Umaima for the amazing teaching points, and Valley for scribing. Thank you so much.
Okay, Umaima, take us away with some of these phenomenal teaching points that you've curated here. Oh, I think you're muted.
Oops, sorry. I'm not very tech savvy either. Thank you so much for the case, Yasmin, and great discussion, Shema and Jack. Okay, so concerning our teaching points, the first thing that we discuss is how like we should not give the stamp of syncope too early, because there are many other causes of transient loss of consciousness. And when we are like taking the history, we should specify with the patients if there were any prodrome signs before the episodes, what the episode looked like, and if it left any signs after the syncope. We discussed the 4 S's of the syncope: sugar, stroke, substance abuse, sleepiness, seizure, and Steele syndrome. For syncope, we should also check for potential causing medications and any potential cardiovascular risk factors. In this patient, the tachycardia was like in a point for like syncope, and if we have like jitteriness and shakiness, it's more for hypoglycemia. The patient's ability to communicate after the episode is a sign that we are probably not dealing with a seizure, because there is often post-ictal confusion. I'm not sure if I wrote that correctly. We also talked about Steele syndrome, since this patient presented with this episode after playing tennis, and in Steele syndrome we have an over solicitation of the upper limb muscles. And we have 3 types of syncope: vasovagal, cardiogenic, and orthostatic. Diaphoresis in syncope isn't necessarily caused by hypoglycemia, but also parasympathetic overdrive if we have chest compression. Shema mentioned that like the combination of high blood pressure and sinus tachycardia can be a sign that we have sympathomimetic toxicity, and she was right about that. And it's important to check the electrolytes, especially with the patient's EKG. And if we're having some trouble reading the EKG or it's complicated, it's important to rule out the most morbid causes first. Jack showed us a very beautiful schema about underlying cardiac causes of syncope. We had structural, cardiac, arrhythmic, and cardiac plus lung, like PE, cardiac plus aorta, like dissection. And yeah, we were all humbled by this case. It was pheochromocytoma. It's not very common, but yeah, it's a lesson to keep an open mind and to consider it next time we are dealing with the syncope.
Wonderful job. Thank you all so much again for coming out. Yasmin, thank you for a phenomenal case. Umaima, thank you for some brilliant teaching points. And Shema, my only request is that you do this with me again sometime down the road.
Absolutely, again. Thank you so much, Jack, and amazing teaching points, Umaima.
See y'all.